likely their hormones are going to be in the normal range, okay, because you're not looking at the free amount of estrogen. Now, Dr. Cox, you see this information. Estradiol is elevated, progesterone is low. I'm going to tell you right now, it's easier to bring the progesterone level up than it is to get the estrogen level down, because you got to get them to lose weight. You got to get them to eat more fiber. You have to get them to take DIM. And you can work on that, but the patient wants to feel better next week. What do? You would try and move this up. All right, so would you give them Provera? Because that's not what we imagine. That's not what's low, right? You would give them progesterone. Okay, so now let me tell you. I think the regular dose of progesterone is somewhere between 50 and 200 milligrams a day orally. And transdermally, the dose is somewhere between 10 and 40 milligrams a day. But when you're using transdermal, you're going to get a lot more absorption or whatever. So let's just say oral. All right. So I've got this much of a discrepancy. Okay? The PE ratio is 24. What would you do for the patient? If the regular dose is between 100 and 200, what would be a reasonable starting dose to try and get that progesterone level up? 100. Okay? So you would give them 100, which is reasonable. It's right mid-range. It's not that big. It's not like her estradiol is 100. It's not that high. So you start right in the middle. So you give it to her, okay? And you would bring her back in a month or two, and you would ask her how she's doing. So hopefully that her PMS is better, and maybe her bleeding is better, all right? And hopefully so subjectively. And then what would you do after that? You would retest her to try and make sure, hey, did I? And then maybe in the meantime, you would tell her to eat more fiber and have more bowel movements or whatever. You would retest her, and hopefully this would be back in the normal range. And now that she's getting a good subjective response, and you've got a good objective response to say that the ratio is there, you would be getting the what kind of response? The ultimate biological response. Okay, so that's what you're looking for. Do I have subjective data that the person's better? And do I have objective data that I have her back in balance? Now I've got the ultimate biological response. I can sleep well at night. I'm not worried about causing her to, have breast cancer, and, I can sleep well because I've done what Spiroff told me to do. Get the ultimate biological response by balancing the actions of the hormones with their respective receptors. And this is the action of the hormone, because I am looking at what is happening in the tissue. And I'm seeing that, hey, she's out of balance, and I'm not giving her any estrogen. This is due to the fact that she's 42. Now that I understand FSH, inhibin, I don't care what her FSH is. I'm not measuring her inhibin. I just want to know what is happening with these hormones. I'm going to get them in balance, and now I can sleep well at night. I'm not confused. I'm not worrying about what NAM says or what ACOG says. I have good information that I can use. This is going to be I'm going to talk about that when I talk about treatment first. Let me get to that when I talk about treatment, okay? I'll give you a little bit of it now. If the person, when you use oral, we talked about like with oral estrogens, you get metabolites. One of the good metabolites from oral progesterone is something called allopregnenolone, okay? Allopregnenolone can easily cross the blood-brain barrier and bind the GABA receptor. The GABA receptor causes calming, okay? So if a person's primary problem is sleep and anxiety, that's what they get. I give them oral. It's a great sleeping pill. Yeah. If it's sleep and anxiety, I go oral. To be honest with you, if it's bleeding like this patient, I just didn't want to confuse you about transdermal, I would probably use transdermal progesterone because I can get a higher tissue level, and I need a high tissue level in the uterus for the bleeding. Okay? So she has some PMS. So but that's if it's mental type symptoms, I definitely want to use oral. If it's more hot flashes and bleeding, I may use transdermal because I get a higher tissue level because it's avoiding the first pass. Okay? But I was trying to make this simple and just say, hey, now that you've got data that you can use, you can make a clinical decision, and that you know that I can follow that decision up with making sure that I was correct or not. You can feel a lot more comfortable with what you're doing. All right, so we're going to end on this. This is on page 636. This is another passage in Spiroff that I had never read before. Estrogen production by the ovaries does not continue beyond the menopause. Now, remember that I said that the hormone has to come from the special tissue in order for it to be released in the bloodstream. After menopause, the ovaries no longer produce estrogen. So if that's the case, if the ovaries are not producing estrogen anymore, then I don't need to go in the blood to look for estrogen because it's not going to be there. Right? Okay. So I don't need to look over there for estrogen because now they're going through menopause, the ovaries are not going to make it anymore. So if I go in the blood after menopause looking for estrogen, I'm 100% guaranteed, according to Spiroff, that I'm not going to find it there. All right? Now, if FSH is a marker for inhibin, and inhibin is made by the dominant follicle. If you are menopausal, you are not making any more dominant follicles. Correct? So therefore, FSH is uninhibited, so FSH is going to rise. So if I use high FSH and blood estradiol levels to determine who needs estrogen, 100% of postmenopausal women, according to those criteria, will need estrogen because all of them, their FSH will go up and all of their blood levels of estrogen will go down. So that means 100% of women need estrogen postmenopausally. Is that right? Clinically, that's not right because we tried that and it didn't work. And we know it doesn't work because if you give everybody estrogen postmenopausal, some of them will feel fine and some of them won't. Okay? But however, estrogen levels in postmenopausal women can be significant, principally due to the extraglandular conversion of androstenedione and testosterone to estrogen. The clinical impact of this estrogen varies from one postmenopausal woman to another, depending on the degree of extraglandular production modified by a variety of factors. So even though the FSH is up and their blood estradiol level is low, these women are still making significant amounts of estrogen, primarily through extraglandular, that means outside of the ovary, conversion of androstenedione to testosterone to estrogen. And this clinical impact, so that means it has a clinical impact. This extraglandular estrogen has a clinical impact, and it varies from one postmenopausal woman to another, depending on how much they make. So if it is made outside of the ovary, I'm not going to see that in the blood, and therefore I am not going to realize that estrogen is causing the clinical problem that I'm looking at. Okay? So if you're using blood levels to tell whether or not a person needs estrogen, you're going to be fooled. You're going to think everybody needs it. The percent conversion of androstenedione to estrogen correlates with body weight. Increased production of estrogen from androstenedione with increasing body weight is probably due to the ability of fat to aromatize androgens. This fact and the decrease in the levels of sex hormone-binding globulin, which results in increased free estrogen concentrations, contribute to the well-known association between obesity and the development of endometrial cancer. Body weight, therefore, has a positive correlation with circulating levels of estrone and estradiol. Aromatization of androgens to estrogens is not limited to adipose tissue, however, because almost every tissue tested has this activity. So what I see that patients, that people are doing, and you're seeing it too, and you also, they're putting all these women on biased or whatever, they're putting every postmenopausal woman on these hormones, and they're still asking the question, do you have a uterus or not? And they're not taking into account this extraglandular conversion that can happen after menopause. But if you look in the saliva, because every tissue tested has this activity, you can look at the salivary level and you can see how much conversion is taking place in the salivary gland, and you get an idea of how much conversion is taking place in other places. So that's why in a postmenopausal woman, I am looking like I told you that lady who was on the Premarin. But I looked at her salivary estradiol and I saw she's making enough estradiol and she's still on the Premarin, and I'm not measuring the Premarin. Where is that coming from? It's from extraglandular sources, and I can see that in the saliva. So every postmenopausal woman that comes in, I never put a postmenopausal woman, I never put anybody on estrogen until I have a salivary test that proves that they are low. Now, I will put somebody on progesterone if they don't have the money for a salivary test. I will put them on progesterone because progesterone really does not cause proliferation, at least when you give it in a reasonable amount. So I will do that occasionally without a test. But I will not put anybody on estrogen. I do not assume that any postmenopausal woman is low in estrogen until I test them, because I have no idea about that extraglandular conversion, especially a woman who is anywhere above 20% above their ideal body weight. I don't take any chance on it because they're more likely to be converting a lot of their androgens into estrogens. Because I don't know where the symptoms are coming from. See, the symptoms can be coming from too much extraglandular estrogen and too low a progesterone. It's not the lack of estrogen that causes the hot flashes, it's the imbalance. So they can come in hot flashing like crazy. And if I do the test, well, I'll show you some menopausal women. If I do the test, their estrogen is normal and their progesterone is low. I bring the progesterone up and they stop hot flashing. Now, here's what happens a lot of times when people are looking at blood levels. They will give them estrogen. So let's say that their imbalance was this. They had this much estrogen, even though the blood level was low, and the progesterone was down. What happens a lot of times if you don't look at salivary testing, you bump up the estrogen and you bump up the progesterone. Okay? So they're imbalanced, but they're imbalanced in a high level. I'm saying you could do this. You see that they're here, and do this. The reason why that's important, that you don't want to do this and this, is when I talk about hormone metabolism, your liver has enough stuff to do to try and get rid of all the toxins that are in the air and what you eat. So you don't want to bombard the liver with more hormone to have to metabolize along with everything else it has to do. So I would rather do this than to do this. So in both of these people, their symptoms will go away. But the ultimate biological response would be to, hey, let's balance them here, and let's let the liver do other stuff. Let me not give it extra work to do. Okay? So, yeah, we think that hot flashes, I got to give them estrogen. I'm telling you, 80% of the people I see, I don't have them on estrogen. Just put them on progesterone. Balances them out. They do fine. Do you have some doctors that just do that? And you get just as good a result? You get some doctors who get good results doing this. But you get some people, you do this, and their liver can't handle it. And their hormone levels will build up quickly, and a lot of times they build up in the imbalanced level. So they may feel good for a month or two, and then afterwards they start to have problems. So I want to know where they start out at. How can I get them in balance as easily and as quickly as possible? I do that, and then if you don't do it, right. It's just going to be at a higher level. Now, here's where all these protocols come in. Because if you don't have good information, you'll see these people, what they do is they do this. And then they'll have a different set of symptoms. And then they'll say, if they come in and they have these set of symptoms, then you need to do this. And then, I'll see patients come in, they've adjusted my hormones 5, 6, 7 times and they can't get it right because they're not getting good information. I'm telling you, if let's say you gave her 100 milligrams, okay? So you did this. You didn't give her enough. She would get some benefit, but she wouldn't get all of the benefit. So what I would do is retest her. and say, oh, I see what happened. We needed to give you a little bit more of this, okay? So you shouldn't have to go 5, 6, 7, 8 times to try and get hormones straight. It's just like, you know, if you were doing blood pressure or whatever, you should be able to take the blood pressure, see where I made the mistake, oh, I need to add this type of blood pressure medicine. But when you're doing these protocols based on symptoms, because there's some symptoms that come from estrogen, progesterone, but then there's also symptoms that come from cortisol, there's symptoms come from this. And so when you're only doing symptoms, it can be very confusing. But when you have some objective data, you can really be able to manipulate those levels and have it make sense. Is lunch out there, Winston? Okay, it's 12:30. Okay, so let's have lunch. I don't know about you, but I'm hungry. Yes?